This podcast is in partnership with Astellas Pharma.
Hey everybody, I'm your four-eyed professor, Chris Lievens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session. Welcome back, everybody, and thanks for joining us on the Four-Eyed Professor podcast today. I'm Chris Lievens, and we're going to dive back into a topic that we covered a number of months back, but in a new way. A while back, we did have a few episodes talking about geographic atrophy in the realm of the world of macular degeneration and how visually destructive that condition can be, and how it's imperative upon all ECPs, optometrists included, to really early identify and bring to the forefront any treatment strategies that we could employ to really help our patients along. We have a first-time guest that I'll be delighted to have on, that I've been trying to find the right opportunity for, and I nailed it this time. So I'm going to bring to the stage Dr. Jessica Steen. Hi, Jessica.
Hi, Chris. Thank you so much for having me.
Oh, I love it. So before we get going, please tell the audience a bit about yourself.
I'm an optometrist. I practice at Nova Southeastern University College of Optometry in Fort Lauderdale, Florida. The majority of my patients have posterior segment disease, primarily glaucoma, and the ophthalmic comorbidities that come with it.
Yeah, so what's interesting is most of my patients are African American, and I don't see the volume of macular degeneration that a lot of my colleagues do, at least not in the same presentations that they tend to see. But I know if I picked up my practice and moved it someplace totally different, it could be a daily voluminous occurrence, because this is really reaching epidemic proportions in a large amount of our aging population.
That's something so key that you mentioned. Classically, we think about that patient type in age related macular degeneration, but we certainly do understand that AMD happens in early and advanced stages in all individuals. So, something so important for us to be aware of is not the specific patient type, but really the patient who's sitting in front of us.
What's wild is it wasn't that long ago where we used to divide macular degeneration into its dry form and wet form and really have a celebration with our patient if they hadn't gotten to the wet form yet. And yet, now fast forward in time, geographic atrophy is part of the dry form, and it can be as, if not more so, visually destructive than wet AMD.
And something so valuable, I think, has really changed the way that I even think about the disease state as a whole. And the more that we learn, the more that we see with geographic atrophy and choroidal neovascularization, I no longer think of these as separate conditions, of course. Really, I describe it to patients that everyone has dry AMD, but also some people develop wet AMD. And to me, that helps to frame the discussion as we're not just thinking about diagnosis and monitoring, but as we're thinking about potential effects that may be increased with treatment options.
Yeah, I love that. So, our goal in this episode is really to talk about how ECPs can recognize the signs of GA, initiate a referral process whenever that's needed. We'll talk about that, and ensure patients are evaluated for whatever treatment options that we have at our disposal. The good news being that there's a ton of R&D into the space, and so we have more today than we've had just 5, 10 years ago, and I expect that to continue to change within the next years in front of us. So, in terms of your patients, so starting tomorrow morning, you know, you're in your day of patient care. Um, what makes you suspect GA? Are there instruments that you use, scans that you evaluate? Do you just use your own visual observations to lock in on this is an issue that I'm concerned about?
So, in a comprehensive eye exam, for me, this starts with clinical evaluation. Certainly, my goal is, of course, to detect disease before the later stage. So, I'm looking for drusen, I'm looking for RPE changes, I'm looking for early to intermediate stage dry AMD from a clinical perspective. And once I've found those clinical features, that's what guides my ancillary testing.
And what types of testing would you consider?
OCT is for me the backbone. So I am carefully evaluating each scan at my workflow platform setting. I'm scrolling through looking for high risk features for progression to geographic atrophy, number one. I'm also thinking about the near infrared reflectance image. I love using the near infrared reflectance image. If there is early geographic atrophy, that will pop up, that will appear in that en face front facing image as a brighter area. Now, OCT, while it is my core, I'll also incorporate fundus autofluorescence, again, to find those subtle areas that may not be so apparent on OCT that can be more easily detectable or more obvious on fundus autofluorescence. Now, the fundus autofluorescence platform that I typically utilize is paired with a fundus or wide field camera, so we will get retinal imaging as well.
So if you're talking to this whole disease state with your students who are novices at this, do you warn them that there could be very subtle things that they could miss, or do you guide them and say, well, if you do these techniques and you really follow what I'm teaching you here, that you really shouldn't miss these?
I think the key is knowing what you're looking for and thinking about, okay, is there reticular pseudodrusen, subretinal drusenoid deposits? Do I see focal areas of outer retinal loss? Are there subtle areas of choroidal transmission? What is the overall drusen load? I think knowing what you're looking for, sitting down at your platform and scrolling through the images one by one really helps you to be able to identify those features.
So I'm going to walk you back to some of the things that you just said. So walk through me a bit slower. What types of things differentiate geographic atrophy from simply and solely dry AMD?
So the real tipping point that we're watching for is complete or RPE and outer retinal atrophy. Looking for loss of the RPE and outer retina on OCT. We'll see this really early on with choroidal hypertransmission defect, that bright, sometimes described as a barcode sign on OCT. And, especially in those fairly early cases, something that's so valuable is incorporation of fundus autofluorescence. Sometimes seeing that front facing image, it is easier to detect early GA than it is as we're scrolling through those careful macular scans.
Yeah, I got you. So when things start to become alarming for you, do you have a criteria in mind, or what's going through your head when you're thinking, do I need to refer this patient to retina?
Really, my criteria for referral has changed since the advent of and the availability of treatment options. And what I try to do is carefully match what my local retina specialist is going to do. And again, how do we get there? How did we get to this place? It's through discussion. It's through real collaborative discussion about case examples. Who are those patients that our retina specialists are most likely to consider treatment in? And based on their knowledge and sharing of that knowledge, that helps me to make better referrals, to counsel my patients more accurately, to ultimately have us working as a team to have what I would consider really successful referral and continuation of care. So, what I'm looking for that again matches at what our local retina specialists are also looking for. Number one is evidence of GA progression. That's a key for us. So, something really valuable is utilizing not just our qualitative information, but the data that our OCT images can give us to quantitatively watch for change over time. What I mean by that is the workflow platform that we utilize gives us specific metrics related to overall drusen volume and also sub RPE illumination, a marker of GA. So I'm watching quantitatively for change, number one. I'm also really considering the patient, their support system, their wants, their goals, and key, their motivation towards treatment. And I am also considering lesion specific features. What are those GA lesions that are at greatest likelihood to progress and progress quickly, meaning multifocal lesions, lesions with that hyper autofluorescent ring. Again, looking at where the lesion's located and considering the fellow eye status as well. So I'm taking the whole picture into play, and we're talking to the patient through this whole process. This doesn't happen at a single visit. This is a series of visits that we introduce the discussion, we introduce the disease. I tell them at every visit what I'm watching for, what I'm seeing, so that if and when it becomes time for a referral for consideration of treatment, they're prepared, they understand, they've got good background information. And the last thing here, I think to be very cognizant of is if there are cases that maybe I'm borderline in considering of referral, I am always going to lean towards referral and to ensure that that retina specialist is able to make the decision that they choose to do so. So for those borderline cases, I'll err on the side of referral just to ensure that I'm not limiting my patient's potential option and treatment.
I think that's really sage advice. The safe approach is and the most conservative approach a lot of times is in the best interest of our patients. But let me back up to one of the topics that you mentioned just before that, and that is your ongoing interactions with the patient. So hypothetically, Dr. Steen, I'm your patient. I'm Chris. I'm in your chair. I've had my eyes dilated before. I know that today you spent more time. And I don't remember having these scans that I had ever before, but today I've had like three or four of them. So I already have some alert and bells going up on my head that something might be up. How do you broach this subject with me in terms of what is means for me now and what could be coming down the road for me?
Well, number one, I hope that I've caught this subtle change early, this early drusen and early RPE change. So I frame it that way. I do talk about the diagnosis. This is age related macular degeneration, which many of our patients have heard about. And this is something that they're deeply concerned about. We talk about, again, treatment options early on. We think about more supportive treatment, nutraceutical discussions, exercise, really lifestyle important or lifestyle heavy habits. Mediterranean diet, best for realistically all of us. Something again that I speak about specifically with patients. And then I talk about what I'm going to do. My goal is to watch carefully for any signs that may indicate progression. Now, again, depending on the patient's risk profile, that will determine how frequently I see the person. Is it every 3 months? Is it 4? Is it maybe every 6 months? And at every visit, I'm carefully evaluating for change. We talk about, again, depending on where they are, we talk about the long term potential that there are treatment options in later stages of the condition. And that's something that I'll say for my patients who have had an AMD diagnosis 5, 10, 15 years ago, a dry AMD diagnosis. When I start to talk about treatment options, I've got really knowledgeable patients that will say, but Dr. Steen, wait, I've got the dry type of AMD. There is no treatment for the dry type. And that is something that has become such a meaningful first step for patients that almost you see it, that it is that little bit of hope that there's something that they had been told in the past that there is no treatment for unless they convert to neovascular AMD, that now in 2025, we have excellent treatment options for.
Yeah, let's talk about that. So, because you're right, because not that long ago, nutraceuticals was pretty much all we had, that diet and exercise. But now we have more, and we will have more looking towards the future. So, Izervay is one of the treatments that we talk about with our patients, relatively often with this condition. What types of language and conversational framing do you use to introduce a treatment like Izervay that they can understand and not overwhelm them?
Well, number one, as optometrists, we're really comfortable in thinking about long term ocular disease management. For me, the discussion is very similar to when I've diagnosed a patient with primary open angle glaucoma. It's thinking about what the condition is and how it can be managed. So, what the goals of treatment are to slow disease progression. Now, we can't get back the damage that has already happened,
Right.
but what the goal is to slow down future damage. And really, this is going to involve a team based approach that it will be a retina specialist who takes over your retinal treatment that is going to require frequent, either every month or every other month treatment long term. And that real adherence, that commitment to therapy is something that, again, is so central to, we're not talking short term, we're talking long term success in preserving the vision.
So, if I put myself again in the patient chair, you say the word treatment, and in my mind, I'm thinking treatment slash maybe cure, certainly improvement. And I conveniently ignored the part where you said you may not be able to recover what's already been lost, and you're just trying to haste or really stop it or slow it down. So, and it's not, and treatments like Izervay, though with massive successes, have not don't guarantee that everyone will respond. So how do you repeat this in a way that patients hear you, and how do you manage expectations?
It's really every visit the same or a similar discussion and getting the patient involved, ensuring that their family members are involved. Really managing the expectation is so key and different from managing patients with glaucoma is that focusing on not again the improvement of vision that we are not going to expect in patients, but the goal of slowing the change over time. Understanding that we know if we do nothing, the vision is going to deteriorate. And with treatment, the goal is to slow that deterioration. We talk about, again, the patient's lifestyle. What is it that they like to do? What are their visual functional features that are so important day to day? And think about, if we can keep that patient doing those things that they love comfortably longer, making those connections often makes the connection for the patient that if there is something that they can do, anything that they can do, they're on board.
So you mentioned the patient, you also mentioned the patient's family. How do you tackle fear on behalf of the patient or behalf of the patient's family? Loss of eyesight is a major concern. It's one of the senses that we tend to take for granted until we start to lose it, and it can induce a lot of things like fear.
And that uncertainty is really where it begins. So that's where, we're talking multiple visits to ensure that we're really addressing questions. We've got, of course, an excellent low vision department that we work very well with. But again, it's more than just coping with their level of vision. It's doing everything that we possibly can to keep them functioning at a good quality, high level visually. And I think really knowing for a patient that they've got the support of not just one eye care provider, but truly a team of eye care providers, including the retina specialist, including the low vision specialist, is something that's really reassuring for the patient and the patient's family members.
So you mentioned before when you find the right time to engage with a retina specialty is based on your conversations with that practice well in advance of seeing the patient. So you know what treatments they're going to employ and when they would like to see the patient in the referral. Do you take that same approach when it comes to low vision care?
Low vision care, certainly what I've learned is that earlier is always better in low vision referrals. Truly, it's something, from a macular degeneration perspective, I generally find that patients are quite receptive to trying to maximize the vision that they have. Low vision, earlier is always better.
So when it comes to treatments, like we talked about, it touched on a bit on like Izervay that can slow down the progression of this disease state. Um, what if you could give every optometrist one piece of advice about managing GA, taking advantage of treatments like Izervay, identifying and managing GA, what are your key points and key take homes for all ECPs out there?
Number one, dig into your clinical examination and your imaging findings. There is real work that we do in, again, truly trying to find any potential findings or biomarkers that increase the risk of disease progression. And once you've diagnosed disease, then our focus shifts to detection of progression. This is really rewarding work. This feeds our clinical curiosity and knowing that patients truly directly benefit from the good hard work that you do in the clinic, really is such a rewarding process and really an excellent example of how interdisciplinary eye care works in its best form.
Yeah, totally true. And so I find a lot of my colleagues, get overwhelmed with technologies that, in all reality, they're using only fractionally toward in comparison to the capabilities that these technologies really can offer them. So, if anybody attending today feels that way, I had a number of tasks last year that we walked through Heidelberg Spectralis as an example and talked about all the ways that we can fully utilize that technology and not just do the basic, really to dive in as deep as possible in the goal to early diagnose and hopefully early manage and early treat early and really take care of patients the best that we possibly can and not wait for the train to get off the rails.
Absolutely, Chris.
Well, you've been a delightful guest today, Jessica. I would hope to have you again. This is massively important information for our patients because this is something that we are all seeing often and critically important for their quality of life and their vision long term.
Wonderful to join you. It would be my pleasure to chat anytime, Chris.
Awesome. Thanks everybody
This
for
has
attending.
ended for today, and we have no exams or grades approaching. Please email me at foureyeedprofessor@gmail.com if there are topics that you would like to hear and see through a professor's eyes.